Hello, hello. Let's talk about cardiology. All right, the agenda. We're going to talk about anatomy, a bunch of equations and basic physiology, get into cardiac cycle and pressure volume loops, talk about different types of shock, pressure, blood flow dynamics, deep dive into action potential and arrhythmias. I really think it's having like a sound understanding of action potentials and arrhythmias. Arrhythmias not even in first aid. Is really going to be helpful understanding EKGs and later antiarrhythmic medications. We'll talk about different types of murmurs, auscultation, combined embryology with congenital heart defects. Embryology is never really worth that much on tests, anyways. Talk about hypertension, atherosclerosis, MI, other ischemic heart diseases. Skipping over vasculitis, then we'll dive into cardiomyopathies and heart failure. Talk about endocarditis, pericarditis, different types of inflammation, and then get into the details for blood pressure, lowering medications, and antiarrhythmics. All right, heart anatomy. So, just gonna basic MCAT overview of the circulatory system. You guys are probably familiar. A little bit more in vessels. Talk about the mediastinum, pericardium, cardiac muscle layers, the coronary arteries, where they originate from, how they feed the heart, the aorta, and then talk about the valves, atrias, and ventricles. So, heart disease, number one cause of death, not just in the United States where we have an obese population, but just in the world as a whole, which was actually surprising to me. Just sort of highlighting how important this particular unit is. All right, you guys, I'm sure, are familiar with this from the MCAT. We go from the right atrium through the tricuspid pulmonary semilunar circuit to the right ventricle, through the pulmonary valve to the pulmonary artery. This is one of the few arteries always go away from the heart. They are typically oxygenated. This is a deoxygenated one. Then we go to the lungs. We're interacting with the alveoli. We're going to drop off CO2, pick up oxygen. Pulmonary vein, so that again, veins go back to the heart, but typically they're deoxygenated. This is oxygenated because it comes from the lungs. The other example of an oxygenated vein is the umbilical vein from the mother to the fetus. Goes into the left atrium, goes through the bicuspid, also called the mitral valve, which is just the atrioventricular valve on the left side. To the left ventricle goes out the aortic valve to the aorta. This then feeds into the systemic circulation, head, nose, feet, etc. Drops off all of the glucose, all of the oxygen, picks up all of the urea, the CO2, all of the garbage, and then brings it back to the heart. So we have our systemic circuit and our pulmonary circuit. And of course, it is not just one capillary bed. There's several capillary beds for the upper body, for the kidneys, for the lower body. Notice that in some cases we have a double capillary bed. That's just called a portal system. We have another one in our pituitaries as well. So we go from the aortas, major highway, branches off into smaller highways of arteries and arterioles, down to the single lane street of the capillaries where the red blood cells have to move single file, then to the venules, to the veins, to the vena cava, and back to the heart. As we're dropping off fluid in the tissue beds for the capillaries, we're going to drop off more fluid than we're going to pick up, and that excess fluid is going to percolate into the drainage, the sewer system, which is the lymphatics, and as eventually is going to merge back into the systemic circulation at the subclavian vein. So at a certain point, probably good to understand the anatomy of all of the vessels. We'll go into this in more detail a little bit later, but effectively we have our tunica intima, which contains the endothelial cells, the basement membrane, the tunica media, which contains the smooth muscle and some elastic tissue, and the tunica externa, which has the vasa vasorum, which is so it's kind of funny, the blood vessels actually have their own blood supply because some of the arteries are so large, and this contains a lot of collagen as well. So major difference between arteries and veins is that there is more smooth muscle in the tunica media of the artery than in the vein. That means that arteries are more elastic and veins are more compliant. You can kind of see that here. Here's our thick tunica media, and here's our thinner tunica media. Capillaries, again, they're very teeny tiny. They don't even have muscle. They just have one little endothelial cell. So they're just one cell thick. We can see an example of this. Veins are squishy. Arteries are not squishy. Lots of muscle, not a lot of muscle. So for arteries, we typically say that they're elastic. So the bulk modulus is the change in pressure of the change in volume. The veins are just going to be the reciprocal of that. The compliance is the change in volume of the change in pressure. So Arteries are like rubber bands. They can snap back. Veins are like balloons. They will just expand. They'll give. Arteries, in addition to passive elasticity, like we see here, have active elasticity, as the muscles will actively contract to generate more pressure and push the blood forward. We see an example of systolic pressure here. So if you were to put your finger right here, this is how you feel a pulse. Every time the heart ventricles contract on the left side, this is going to push a ton of blood through the circulatory systemic circuit, and you're going to feel that with your finger. It's generating a high amount of pressure. Now, that pressure would be much, much, much smaller if it wasn't for the elasticity of the muscles. So the muscles are kind of acting like a pressure reservoir. They're storing a bunch of the energy here. Otherwise, all of the pressure, all of the energy, velocity, et cetera, would go in this direction, but some of it is somewhat stored here so that during diastole, which we see here, we can have a little bit of elastic recoil springing back, which just continues the blood forwards. So when we're measuring pressure, blood pressure, we're measuring the artery, typically the brachial artery, and it's a lot higher than the venous system for a lot of reasons. Mainly in the same way that in physics we can have a high voltage become a low voltage when it moves across a resistor. Same thing here. The resistance of mainly our arterioles, honestly, are going to dissipate a lot of that sort of pressure energy. So we have high pressure, and then as it moves through the arterioles, it loses a lot of that pressure, and now it's in a low pressure state. So the venous system is much lower. In addition to the fact that the venous system, as we said, has less of a tunica media, less elastic tissue and muscles. And it oscillates. Here we see the systolic pressure, here the diastolic pressure. Yes, it dips. It would dip even more if it was not for the elasticity of the muscles. Notice also that the mean arterial pressure is closer to the diastolic than the systolic side, and that's just because diastole is longer, so it's effectively twice as long as the systolic pressure. So if arteries are pressure reservoirs, then veins are volume reservoirs. Here we can fit some in our veins, we're going to fit the blood. And if we put in more blood, then they're just going to expand. They're not going to necessarily snap back like an artery. So most of the blood in your circulatory system is in fact stored in the veins and venules. This is going to come back when we look at pressure volume graphs, venous return graphs. So because they don't have much pressure to rely on getting blood through the venous system, we have skeletal muscles which can contract, which can push blood forwards. On top of that, we're going to have valves which prevent the backflow. And so when you are on a long flight, they say walking is good for your circulation. Yeah, one of the reasons is that the pumping of the calf muscles and other muscles is going to sort of milk the blood through the venous system back up to the heart. So just a little summary of that, you can think of arteries as a pressure reservoir. So if we looked at a particular volume over here, so particular volume X, we're going to have a small amount of pressure in the veins and a large amount of pressure in the arteries. So we're seeing that there is a large storage of pressure in the arteries, large storage of energy to some extent. And for the veins, if we looked at a particular Y pressure, we're going to see that there's not much volume in the arteries, but there's a ton of volume in the veins. So volume reservoirs versus pressure reservoirs. And the arterioles, as I mentioned, contribute mostly to the resistance. So the thing to look at here is the fact that the arterioles have a lot of smooth muscle and they have very little elasticity. On the top of the fact that they are particularly small, and a small diameter is going to give you a large resistance. So the veins, on the other hand, don't have much smooth muscle, are much more compliant. AV malformation versus fistula, these are more or less very similar. For the AV malformation, blood's passing through too quickly. It's not branching off into all of the smaller capillary beds that we would like to, individual capillary vessels. So we get AV malformation shown there. AV fistula is very similar, but I think this is just and typically an artificial, a lot of times they'll do this in a surgery, combining an artery with a vein where they actually shouldn't be connected. So rather than the capillary bed not working, it's just the connection is at some place where it shouldn't be. Mediastinum is really just in between our two lungs over there. And again, in between our two lungs, here's our mediastinum. This is really just where our heart is, in the thoracic cavity. The anterior mediastinum contains the thymus. The posterior mediastinum contains the esophagus and the aorta. And then the things like the heart, pericardium, ascending aorta, descending and ascending vena cava inferior, superior, all going to be in the central middle mediastinum. Notice the left atrium is on the posterior side, so it's going to be interacting with the esophagus. The left ventricle is obviously on the left border. It's kind of on the posterior as well. And then the right ventricle is on the anterior side and on the right. And then the aorta is going to sneak through, poke through the pericardium, as we'll see in a second. So the pericardium, it depends how we want to quantify the layers, not so important. On the outside, we have the fibrous pericardium, and then on the inside, we have the serous pericardium. In between the parietal pericardium, which we can see right here, we're going to have a lot of the pericardial space, pericardial fluid, which pericarditis, we can see this inflamed, cardiac tamponade, we can see lots of blood leaking here, and that can be bad, can compress the heart. The serous pericardium, so it's going to be on either sides of this pericardial space. Parietal is on the outside, visceral is on the inside. The visceral pericardium is sometimes just called the epicardium. It's covered in adipose tissue, so if you go to your Complete Anatomy app and you look at the epicardium, it's often covered in fatty tissue. And so this just houses, insulates the heart. You can think of it, a lot of people make the analogy to a balloon. So it doesn't go all the way around the heart, right? We need a way for the vessels to get in and out. So the aorta, the vena cava, the pulmonary arteries and veins, et cetera, are going to come through this top portion. And so it'd be like if you push your hand into a balloon. So the outside here being the parietal pericardium, the inside being the pericardial space, pericardial fluid, and the inside being the visceral pericardium, also known as the epicardium. Fibrous pericardium would be over there. The pericardium innervated by the phrenic nerve. So if you have pericarditis, it might refer pain to the neck or the shoulder, which are also innervated by the phrenic nerve. The fibrous nature of the pericardium prevents it from overfilling, which would be bad, contribute to something like a dilated cardiomyopathy. So the pericardium is covering the heart. Heart has these three muscle layers, which we'll see here. So we have the epicardium, also known as the visceral serous pericardium. We have the myocardium, which you'll see is the thickest layer by far, and it's has the largest oxygen demand. And then the endocardium, which is the deepest on the inside, which is going to be in contact with the fluid. The blood is going to be right over here interacting with the endocardium. And very important is that the coronary artery arises from the epicardium. So the coronary artery originates here, we might say, and then it extends through the myocardium all the way into the endocardium. Again, over here is the lumen, which is really just where all of the blood of our atria and our ventricles are. And it might seem kind of silly, like there's so much blood around. Why don't we just take some of that blood and feed the myocardium itself? It's because this might be thousands and millions of cells thick. Diffusion really only works at a small distance, so we need the coronary artery to penetrate and permeate the myocardium to feed it, really. Right atrium just receives its nutrients, not its nutrients, but it receives the venous blood from the superior inferior vena cava. We know that. Right atrial, fun facts. It has the sinoatrial node. It also has the atrioventricular node. It has something called the foramen ovale, is what you have as a fetus, where blood can flow from the from the right atrium to the left atrium, which will be high pressure and then low pressure. Notice that's the reverse of the order as an adult, where the left atrium is at a higher pressure. The remnant, the vestigial feature, is called the fossa ovalis. Sometimes it doesn't close. People have a patent foramen ovale, which we'll talk about. We also have the coronary sinus. So the sinus is, if the coronary artery is what's feeding the heart tissue, then the venous system for the heart tissue is going to collect the coronary veins into the coronary sinus, which is in the right atrium. It's also on the very rightmost border of the heart. The tricuspid valve, an atrioventricular valve that separates the right atrium from the right ventricle. We're going to pump through the pulmonary valve into the pulmonary arteries, which are blue, which are deoxygenated, as we said, and these are going to go to the lungs, pick up oxygen, and then we're going to go to the left atrium and the left ventricle. Why is this so thick? The left ventricle has a much harder time pumping blood all the way to your head and your knees and your toes. That's a taller order, so we need more muscle for the ventricles to contract. This is the interventricular septum separating the left ventricle and the right ventricle. And the right ventricle, as we're seeing, is a little bit thinner. And yeah, the left ventricle is just pumping through the aorta to the rest of the body. Left ventricle is going to be, so again, this is the interventricular septum. It's going to be in the left border. It's a little bit on the, it's not as anterior as the right portion of the heart. And it's going to contribute to it's going to touch the apex of the heart right over here. And it's going to contribute a little bit more to the posterior side if we look at it from the back over here. We mentioned this earlier. You cannot feed the myocardium with diffusion. Instead, you need a coronary artery sort of originating from the serous, like the serous visceral pericardium, also known as the epicardium. And then this is just going to feed through and feed the myocardium. As we mentioned, the left ventricle through the coronary arteries feeds the myocardium, and the cardiac veins will drain into the right atrium and the sinus, and these originate in the epicardium, also known as the visceral serous pericardium. So if there was a myocardial infarction, a heart attack, who's going to get screwed over? If it's a small one and it's originating the epicardium is going to be the last to start because that's where the coronary arteries are sort of starting. We can think of it that way. So the myocardium, the endocardium are going to be the first to die off or become ischemic. But if you have a big MI, then it's going to be what we would say is transmural. It's going through all three muscle layers. So we'll talk more about that later. Coronary as in king, as in Crownley. And they just thought that, if this is my aortic valve, the coronary arteries kind of originate off of this, and they look like a crown going, I don't quite see it, but I guess I get it. Heart valves. So we have the two atrioventricular valves, which are the mitral and tricuspid. The mitral is also known as the bicuspid. Why? Because it just has two of these, while everyone else has three. The pulmonic over here, and then the aortic over here. Major issues with these is they can become stenotic, which just means it takes a lot of pressure, a lot of effort to open them. They're a little bit stiff, and like a door that's stuck. And then regurgitation is blood is actually going to leak backwards. They're not closing properly, so a bunch of stuff is blowing backwards. If we're looking at this, we're looking at the here's our tricuspid, here's our bicuspid. But which one of these is the aortic versus the pulmonic? Well, we should be able to tell. First of all, it's red, which means it must be oxygenated. So this is going to be the aorta, and this is going to be the pulmonic. On top of that, the coronary arteries are originating from them. They don't originate from the pulmonic, they originate from the aortic. So if we're looking at the aortic root is just the bottom, like this is basically the left ventricle right here in the aortic valve. So the aortic root is just sort of the beginning. Ascending aorta, descending aorta, down, we're going to say that this is the abdominal aorta. And the right coronary artery, left coronary artery are just branching right off of these. So the coronary arteries, as we said, are going to originate right at the beginning of the ascending aorta. They can, very important, they can only fill and feed the myocardium during diastole. So during systole, these flaps are basically going to press over the coronary sinus here, the opening into the coronary system, blocking entry. And so blood is just going to go in this direction. But when it's relaxed a little bit, when the valve closes, it now stops covering the coronary opening, and so blood can get through there. I think we'll see a better picture later. So they can only fill during diastole. So that'll come up again and again. So the coronary, coming from the aorta, we have the right coronary artery and the left coronary artery. The right coronary artery goes to the acute marginal artery, which just feeds the right ventricle. The posterior descending artery, the PDA. Most people are going to be right dominant, which just means the PDA originates from the right coronary artery, not the left coronary artery. If this is the case, it feeds the AV node. It makes sense. This is in the right atrium. And the interventricular septum on the posterior side, well, this is the posterior descending artery. So that all sort of checks out. The left coronary artery has the left anterior descending artery, also known as the widowmaker. I guess men men are disproportionately at risk for myocardial infarctions, and this might be lethal. And so the idea is that they would make their, this artery is responsible for generating a lot of widows. The LAD going right down over the sort of the center of the heart in between the left and right ventricles, the interventricular septum on the anterior side, the left ventricular wall, and the anterior, the lateral was always a little confusing to me. I just think of the fact that it's anterior. That makes sense. The LCA, the LAD is on the anterior side, so this is the anterior papillary muscle. There's two papillary muscles that are holding on to the mitral valve, chordae tendineae. LCX, the lateral, the left circumflex artery. Sometimes the PDA can originate from this, which is really just from the left coronary artery. So this would be left dominant. This is obviously not as common. This could feed the left ventricular wall. And then the posterior medial papillary muscle. So again, I just think about the posterior. It makes sense. The LCX is sort of going over here. And then shown on the posterior view, it's snaking over here. So it makes sense that it would get the posterior left ventricular wall and then the posterior papillary muscle. By the way, the ventricular walls, especially the anterior side, are going to be really important from like 1 to 2 weeks after a heart attack. This is very prone to rupture, which could result in a pseudoaneurysm, cardiac tamponade, or just, it's pretty bad to have a giant hole in the middle of your heart. So, and then we have the obtuse marginal artery. Nothing to write home about that. So am I bad at math? No. What is it? Like 7% of people might be co-dominant, meaning the PDA can sort of arise from both. So there's a bit of redundancy there. So the AV valves, they have chordae tendineae, which grab on to the valves, preventing them from prolapsing, pushing into the atria. And then the papillary muscles are going to kind of give them tension. We'll see a picture of this in a hot second. So here's our valves, here's our chordae tendineae, and here's our papillary muscles. And so, blood can't get in when this is closed, right? If it's during ventricular systole, I want to pump blood through the pulmonary valve and the aortic valve. I don't want to pump it back into the atria. That would be really bad. If you've got blood flowing in both directions, it's no bueno. That's bad. And so this can prevent that, but we also don't want the valves to kind of balloon up into, which you'll see in mitral valve prolapse. So this is why we have that there. So without them, you're going to have regurgitation occur. So during systole contraction, some blood is going to the atria. Whoops. So why would mitral stenosis cause dysphagia and or hoarseness? Well, if you have mitral stenosis, you have a very stubborn, stiff mitral valve. You try to pump blood or push blood from the atria to the ventricles, but it's a little bit difficult. So we need a little bit more of an atrial kick, a little bit of a stronger one. So there'll be hypertrophy and enlargement of the left atrium. And the left atrium, so we'll notice that this is actually not how the heart sits. And that rotation is actually quite key. This is the apex here, and then the left side's a little bit more on the posterior. And so the left atrium is actually very posterior. So the left atrium is by far the most posterior thing, like we mentioned earlier. It's going to compress on the esophagus and cause dysphagia, trouble swallowing, and it's going to compress the left recurrent laryngeal nerve, which is going to cause hoarseness. And again, we see a picture of the left atrium is in connection with the esophagus. Cool.